Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programmes, Postgraduate Diploma in HIV Medicine, PGDHIVM, MCMM, 001 Basics of HIV Infection, Block-1 Epidemiology of HIV, Unit 2 times Transmission Dynamic, 2.0 Objectives. After completing this unit, you should be able to describe the host factors that are responsible for HIV transmission, identify various modes of HIV transmission, explain the transmission dynamics of HIV infection in a given population, and define relationship between women and vulnerability to HIV infection. 2.1 Introduction. A steady state of disease condition in the community is observed whenever equilibrium is arrived between disease agent, host, and the environment. Any change in the equilibrium would lead to altered transmission dynamics and thus, a change in disease status. You have already learnt about the disease agent, i.e., IgG4 in previous section. In this unit, we will discuss the host factors that influence the transmission dynamics of HIV infection and HIV transmission routes. We expect that you would become knowledgeable to answer questions that are given at the end of the chapter. If you are unable to answer them, please go back to the relevant section of the chapter and read carefully and you would find the answer. 2.2 Host factors. There are various risk factors that are responsible for HIV transmission. These factors are following. 2.2.1 High risk group. HIV infection does not follow a uniform course in all societies at all time. In fact, there is sufficient evidence to conclude that HIV infection affects different geographical area and different population subgroups differently at different times. The highest prevalence of HIV infection is observed among most at-risk population, MARP, i.e. populations with high levels of HIV risk behavior. Common high-risk populations are female sex worker, FSW, men who have sex with men, MSM, and injecting drug user, IDU. These population subgroups are often also described as high-risk group, HRG, or core transmitters. If surveillance data for year 2008 to 2009 revealed that in India the highest HIV seroprevalence was among MU, 9.2%, followed by MSM and FSW, 7.3% and 4.9% respectively. The initial appearance of HIV infection in any geographical area is first noticed among the HRG subpopulation. The transmission is intense within this population subgroup. Once the infection is established in the HRG, it further spreads to the sexual contacts or injecting drug partners of HRG. The male clients of female sex workers, truckers and their helpers, single male migrants are the next high-risk category, often described as bridge population. They are so called because this population subgroup helps the HIV infection to traverse from highest risk category population to the population that has virtually no known HIV risk behavior. HIV epidemic in India is primarily driven by interaction between HRG and the bridge population. Bridge population further transmits the infection to their spouse or girlfriends. These female sexual partners can further transmit the HIV infection to their unborn children, where the infection reaches the dead end. This stage of epidemic is called truncated epidemic. 2.2.2 Risk behavior and spread of HIV infection. Tim Brown has developed a model to explain the transmission dynamics of HIV infection in a given population that is reproduced below. Figure 2.1, HIV transmission dynamics. Tim Brown's model. 2.2.2.1 Spread of HIV infection from FSW. The model assumes that a fraction of male population accesses female sex worker and could acquire HIV infection if the sexual encounter is unprotected. Thereafter, this infected male could further transmit the infection to the following persons. 1. If the male is married or has other sexual partners from the general population, e.g. girlfriend, spouse, he could transmit the infection to his girlfriend or spouse. 2. Some of the male clients of female sex worker, FSW, may be bisexual. In such a scenario, the male partner of this infected male may get HIV infected. 3. The male client of the FSW may access other female sex workers as well. If any of the other FSWs are still uninfected, they might get infected from this male. Thus, an unprotected sexual encounter between FSW and her male client has a potential to spread the infection to other population subgroups. 2.2.2.2 Spread of HIV infection from MU. The NTV transmission dynamics among injecting drug users is a slightly different than the sexual route of transmission. The principal risk factor in this group is sharing of UN sterile injecting equipment. As described in Table 2.1, the risk of transmission by infected needle is high, 1 in 150. Sometimes, the ilitildate drug is diluted using blood drawn from vein of the infected individual. HIV transmission through infected blood has the highest risk of transmission, almost 95%. Therefore, HIV transmission within a group of IDU that share infected needle and syringe injecting equipment is intense. The HIV prevalence among IDU, therefore, quickly reaches its peak, mostly within 3 years of its introduction. The pattern of networking of LDU would determine how widespread the infection eventually would be. An IDU can further transmit the HIV infection to population subgroups other than IDU in following manner. 1. If the male IDU is married or has other sexual partners from the general population, e.g. girlfriend, spouse, he could transmit the infection to his girlfriend or spouse. 2. Some of the male IDU may be bisexual. In such a scenario, the male partner of this infected male may get HIV infected. 3. The male IDU may access other female sex workers as well. If any of the other FSWs are still uninfected, they might get infected from this male. 4. In order to support their drug habit, many of the IDU, both male and female, may resort to sex work. In such a case, their sexual clients are at risk of acquiring HIV infection. 2.2.2.3 Spread of HIV among general population. The general population is envisaged as a group of persons that do not have any known HIV risk behavior. However, HIV infection may be observed in this group as well. Most of the spouses of male clients of FSW do not have any risk behavior. They get infected due to the behavior of their husband. Spouse of an infected person may further transmit the infection to her unborn children through vertical transmission, i.e., from infected mother to child. This mode of transmission has been described in this chapter as perinatal transmission. Other routes of HIV transmission to the general population are through transfusion of contaminated blood or blood products, transplantation of tissues or organs, or donated semen that is infected. MV transmission in these cases is due to the role of medical professional, and therefore it is classified as iatrogenic transmission. 2.2.3 Role of sexually transmitted infection, STI, in HIV transmission. Most of the HIV transmission in India is through heterosexual route. However, the efficiency of HIV transmission through this route is poor. The presence of STI that cause ulceration or inflammation enhances the transmission efficiency. Presence of such STI leads to higher viral shedding by infected person, infectiousness, and increased susceptibility to HIV acquisition by an infected person to the exposure. Persons with non-ulcerative STI have 2 to 3 times higher risk of acquiring HIV infection. The risk increases 2 to 11 folds in the presence of genital ulcer. 2.2.4 Circumcision and risk of acquisition of HIV infection. It is known from experimental animal studies that the Langerhans cells beneath either mucosa are the first cells to be infected. The mucosa in the prepuce and glands of male contains significant amount of Langerhans cells. Presence of prepuce allows the infected genital secretions to remain in contact with the mucosa of the glans penis for a longer period, thereby increasing the risk of HIV acquisition. Circumscribed males that do not have prepuce and where the mucosa of the glands has keratinized are at a much lower risk of HIV acquisition. 2.2.5 Women and vulnerability to HIV infection. Women are at a higher risk of acquiring HIV infection as compared to men due to the following reasons. Biological reasons. Risk of HIV transmission from infected male to uninfected female is much higher as compared to from infected female to uninfected male. Higher risk of HIV transmission for female is due to the longer duration of retention of infected body fluid, i.e. semen. This results in longer contact period of infected material with the mucosal wall of vagina, and therefore more efficient transmission of infection. Moreover, the total surface area of vaginal mucosa is greater than the mucosal surface area of glans penis of male. Greater the exposed mucosal surface area, higher the probability of contracting the infection. Women often suffer from sexually transmitted infections, STIs, sometimes without any symptoms. As described earlier, if the woman has STI, even asymptomatic, then the risk of HIV acquisition is enhanced. Though it must be reiterated that HIV can be transmitted even in the absence of STI, Women get married at a younger age as compared to men. The vaginal mucosa of women at a young age is immature and therefore much more vulnerable to HIV acquisition as compared to women that have mature vaginal mucosa. Social status: the status of the women in society is lower than men. Many of the women are socially marginalized and or economically dependent on men. They may have lower rate of literacy that reduces their awareness about HIV/AIDS. They have lower access to health care, resulting in poor health and concomitant infections including STI. As a consequence, they are unable to negotiate safer sex and thus making them socially vulnerable to HIV infection. Epidemiological data from India suggest that the only significant risk factor for HLV infection among an average Indian woman is having sex with their spouse. 2.2.6 Natural immunity to HIV infection. Some persons, including those that are at the highest risk of HIV acquisition, example female sex workers, when exposed to HIV infection are known to remain uninfected. It is believed that such resistance to HIV infection may be due to the gene responsible for expression of receptor CCR5 had a missing 32 base pair in homozygous manner. 2.2.7 Infectiousness of HIV-infected person. There is long and variable period of incubation between acquisition of HIV infection and development of AIDS. During this period, the infectiousness of the person varies and is related to the amount of virus present in the body fluid during the natural course of disease. Two peaks of viremia are seen during the primary HIV infection and while the person is seroconverting, i.e. during the initial stages of infection. First peak is seen. Thereafter the viral load typically falls to low levels and may even become undetectable. Viral load starts to rise again high when an infected person develops AIDS, defining illness signifying complete breakdown of immune system and giving rise to the second peak of viremia. 2.2.7.1 Viral load. The level of viral load between the two peaks is determined by balance achieved by factors that enhance the viral replication while others that try to suppress it. Whenever the immune system of a HIV-infected person is activated, the viral replication is enhanced. This can occur most often due to concurrent infection by bacteria, protozoa, helminths, or other viral infections. The transient increase in viral load returns to baseline once the concurrent infection is successfully treated. However, every episode of temporary increase in viral load also accelerates the progression of infection to AIDS case status. Therefore, efforts should be made to prevent occurrence of opportunistic infections, and once they do occur, a vigorous treatment should be immediately started. The immune activation leads to increased levels of HIV-inducing cytokines, e.g. tumor necrosing factor alpha, interleukin, Illinois.jl beta, and Illinois 6. The impact of HIV-stimulating cytokines are counterbalanced by those that suppress the HIV replication, example CD8 T cells. Thus, the level of virus in the blood of an infected person remains in dynamic state. The higher the viral load in the body fluid, the more infectious the person is for the uninfected partner. 2.2.7.2 Window period. Most of the HIV screening test currently in use is based on assessment of antibody to HIV infection. Since body takes some time, usually 4 weeks, to mount a detectable antibody response to HIV infection, the screening test is likely to fail to detect the infection. This period when the virus is present within the body but a measurable immune response is yet to develop is called window period. It is pertinent to remember that during this window period, while the infected person is seroconverting, there is very active viral replication and the viral load is very high, figure 2.2. Hence the window period carries a high risk of HIV transmission. The risk of HIV transmission during seroconversion is 1 in 25 to 1 in 1,000, whereas during asymptomatic stage it decreases to 1 in 1,000 to 1 in 10,000. If an infected person is on antiretroviral therapy, ART, then the viral load is suppressed and in fact may not even be detectable. Thus the risk of HIV acquisition for any single act of unprotected sex would depend on the stage of HIV infection and medication, ART, if any. 2.2.7.3 Infectiousness of body fluids. HIV transmission occurs when body fluids of an infected person comes in contact with blood or mucosa of an uninfected person. Fluids that are manufactured by the body are called body fluids. Those fluids that are known to transmit the HIV infection are semen, blood and blood products, vaginal, cervical secretions, breast, milk, and amniotic fluids. HIV virus is also found in tear, saliva, cerebrospinal fluid, urine, and sweat. However, the amount of virus present in these body fluids is very little. Theoretically, such body fluids can cause transmission of HIV infection, but in practical terms the risk of transmission is insignificant. Various routes of infection and the attendant risk of transmission are given below. Table 2.1, Route of infection and risk of transmission. 2.3 HIV transmission routes. There is no known intermediate host for HIV virus. Thus HIV infection is transmitted from one human being to another. Broadly speaking, the routes of transmission could be categorized as follows: 1. Sexual, 2. Parenteral, and 3. Perinatal. 2.3.1 Sexual route of transmission. Any unprotected penetrative sexual intercourse, whether heterosexual or homosexual, could result in HIV transmission from one infected person to another, uninfected sexual partner. Among the sexual route of transmission, penetrative anal intercourse has the highest risk of HIV transmission, while oral sex, defined as sexual activity which involves mouth contact with another person's genitals or anus, has the lowest risk. Table 2.1. Anal mucosa is highly vascular and there is no natural lubrication during sexual intercourse. Hence, tear of anal mucosa, even if microscopic, during penetrative sex provides greater opportunity for intermixing of blood and semen. In addition, once the semen is deposited in the anal canal, it remains there for longer period and has access to large mucosal surface area. Therefore, penetrative anal sexual intercourse carries increased risk of HIV acquisition for the receptive partner as compared to the penetrative partner. The strategy to prevent sexual route of HIV transmission is abbreviated as ABC, strategy signifying abstinence, be faithful, and condom use. If there is no sexual contact, then obviously HIV transmission cannot take place through this route. One may term it as primary prevention. However, sexual gratification is one of the basic human needs, and this strategy cannot be widely practiced. One could advocate for delayed sexual debut. Deferred sexual initiation allows a person to become more mature and be in a better position to assess the consequences of sexual encounter. They may be able to understand and implement preventive measures, e.g. use of condom due to greater maturity. The second component of the strategy, i.e., be faithful, of great practical significance. Monogamous sexual relationship between two uninfected partners is the best guarantee of HIV-free status. HIV transmission is significantly reduced by engaging in safer sexual behavior that includes non-penetrative sex and use of condom during penetrative sex. Proper use of condom provides significant protection against HIV transmission. 2.3.2 Parenteral route of transmission. Transfusion of contaminated blood has the highest risk of HIV transmission. Screening of donated blood, blood products, tissues, and organs before being used in a recipient is the only way to reduce the parenteral route of transmission. Tests that are based on detection of virus, e.g. P24 antigen polymerase chain reaction for proviral DNA, should be employed to assess the HIV status of the donated material. Healthcare workers are often afraid of contracting HIV infection during their routine care of their patients. Best way to reduce HIV transmission to healthcare provider is to observe universal precaution. This strategy is based on the premise that all patients are potentially HIV infected irrespective of their HIV test result. Such a precaution not only reduces the risk of MV infection but also that of all other blood-borne infections. One of the commonest errors of health workers that could result in needle stick injury is while they try to recap the needle or try to bend it after use. In such a situation, a well-defined protocol for post-exposure prophylaxis is available and has been described in another section of the module. 2.3.3 Perinatal route of transmission. Transmission of HIV infection from an infected mother to her fetus or infant, before, during, or shortly after birth is called perinatal transmission of HIV. HIV crosses placental barrier and therefore a fetus can get infected in utero. During the delivery, the fetus is exposed to the secretions in birth canal that contain virus. The infected secretions can be ingested by the fetus and thus HIV transmission could take place. Small amount of virus is also secreted in the breast milk, and a breastfeeding child therefore could acquire infection from this route as well. The risk of HIV transmission through breast milk is lower among infants exclusively breastfed as compared to infants on mixed feed, i.e. a combination of breastfeed and top feed. Almost 1/3 of all children born to HIV-infected mother in developing country become HIV positive. The total risk of HIV acquisition is almost equally divided in 3 stages, i.e. during pregnancy, during delivery, and during breastfeeding. Some countries have tried to reduce the risk during later 2 stages by resorting to delivery by caesarean section, along with cessation of breastfeeding. If this approach is coupled with administration of ART during pregnancy, the risk of perinatal transmission could be virtually eliminated. In India, the government has launched Prevention of Parent-to-Child Transmission (PPTCT) program wherein pregnant mother and, later on her infant are provided with ART. 2.4 Summary. Let us recapitulate some of the important facts and concepts that we read in this chapter. We have come to understand that not everybody in a given community is at an equal risk of acquiring HIV infection. A small subpopulation, known as HRG, are at a much higher risk of HIV infection. Presence of sexually transmitted infection, particularly those that cause ulceration, enhance the efficiency of HIV transmission. The risk of HIV infection varies during the course of HIV infection and is dependent upon the viral load. HIV transmission through heterosexual route is relatively inefficient. However, due to sheer size of the sexually active population and high frequency of sexual act, the commonest mode of HIV transmission in India is heterosexual route. Women are more vulnerable to HIV infection due to biological and social reasons. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.